Thank you very much for inviting me to present on children's health in metabolic bone disease here. I'm delighted to be here. I'm a consultant pediatric endocrinologist at Royal Manchester Children's Hospital. I manage children with metabolic bone disorders, including brittle bone disease. In today's presentation, I will discuss common clinical features which are seen in brittle bone disease, investigations which we carry out for diagnosis as well as management of brittle bone disease. And then I will discuss what we do for children and adolescents who suffer from brittle bone disease. So what is osteogenesis imperfecta or brittle bone disease? It is a genetic condition which causes increased fragility of the bones. Since it's a genetic condition, there is usually a family history of brittle bone disease. Either parents suffer from it or there are siblings who suffer from it. The most common form of brittle bone disease is because of a defect in type 1 collagen fiber, and it is numbered from type 1 to type 5, and these are the autosomal dominant brittle bone disease. There is half a chance of children being affected with this condition. Then there are various autosomal recessive disorders which have been described where parents may not be affected, but there could be a history of sibling affected with this condition, and it tends to be much more severe when it is autosomal recessive. Now, what are the common features of osteogenesis imperfecta or brittle bone disease? As the name suggests, it is mainly a history of recurrent fracture. There is usually a family history of fractures as well, but if there is no family history of fracture, it doesn't mean that child doesn't have a brittle bone disease. As I mentioned, that sometimes there is no family history, but still it is a genetic condition. Because it's a defect of type 1 collagen, which is present in bones and various other connective tissues, other connective tissues are also affected, and there tends to be hypermobility of joints. In some children, fractures are not that much of a problem as is the hypermobility of joints because it causes significant aches and pains. Blue sclera is another feature of osteogenesis imperfecta, but not all children with brittle bone disease have it. And similarly, teeth can be affected, but not all forms of brittle bone disease dentition is affected. So these are the common features which are seen in brittle bone disease. Now, what are the investigations which we undertake to diagnose brittle bone disease? Unfortunately, there is no definitive biochemical or imaging marker for brittle bone disease. We usually tend to look at history, family history, and perform radiology to make a diagnosis of brittle bone disease. There are various features which can be seen in children with brittle bone disease. If you take X-ray of the head, of the scalp, then there could be Vermean bones. So there are sutures in between the major bones in the skull, and it tends to be the major sutures are there, but there could be some minor sutures as well. But in brittle bone disease, there could be islands of bones with multiple sutures on the back and top of the bones, which could be seen on skull X-rays. But then, again, not all children with brittle bone disease have it. X-ray of the backbones can reveal crushed fractures. Again, it's not a diagnostic feature of brittle bone disease, but it is one of the complications which we look for when it comes to management of brittle bone disease. Children can have generalized osteoporosis. It's about lack of minerals and proteins within the bones, and this can be measured by bone density scanning. In milder forms of brittle bone disease, the bones can be thin, they are slender, and they have a thin outer shell known as cortices. In the severe forms, the manifestations are more marked. The bones are quite broad, they are shorter, and there could be multiple fracture with callus formation. For a definitive diagnosis, one could do a mutation testing in gene coding for type 1 collagen fiber, and this is for the most common form of brittle bone disease, which is type 1 to type 5. There are other rare autosomal recessive where other genes could be involved. We don't tend to undertake this investigation in children who have brittle bone disease, especially if there's a family history and if there's a clear clinical picture. Only if there is a doubt about diagnosis and if there are other social implications, then we undertake this investigation. The cost was quite high, but it is coming down of performing this investigation. Now I will move on to management of brittle bone disease. Unfortunately, there is no specific cure for brittle bone disease. Science hasn't advanced to a stage where we can completely cure this condition, and management is mainly by supportive care. We should share our experience, because by sharing our experience we learn. When a patient and a family comes to my clinic, I share my experience and they share their experience, and I learn from them and they learn from me. It's good to join a group where we can share experience, and Brittle Bone Society provides a platform for us to share our experience and learn. And in all my patients, I encourage them to contact Brittle Bone Society so that they could come over and learn from them, and also gain support from Brittle Bone Society. It is important to identify a medical team for management of brittle bone disease. Throughout UK, there are various tertiary centres which manage children with brittle bone disease. If you are far away from these tertiary centres, you will have local contacts, and we will have a shared care arrangements with your local hospital to manage this condition. You would require at least a yearly contact with tertiary unit for overall management, to look for any complications which could be developing. If brittle bone disease is of severe nature, then you will require more regular contacts with your medical team. It is important to have a documentation with you which confirms the diagnosis of brittle bone disease. This is very helpful, as there is increased awareness about child abuse, and any fracture which is unexplained, there is always this child protection procedure which starts occurring. Most of the children with brittle bone disease, the history does not correlate with the type of fracture they develop, and therefore it is good to have a letter stating that child has brittle bone disease and is likely to develop fracture with trivial trauma. I tend to provide this to all my family members in multiple copies so that they can keep with them when they are going on holiday. They can have it with them as well. Management starts from very early age, especially if fractures have been identified before the baby has been born, or if there is a family history of brittle bone disease immediately after birth. If there are features of brittle bone disease, we'd start giving advice on protecting the bones and especially the spine. The first thing would be to make sure to have an infant seat which reclines as much as possible to avoid pressure on the backbones. Stroller as well should recline as much as possible, and there should be sufficient space for padding so that it can absorb shock to prevent any fractures. Care is very important when babies are handled, especially when the babies are lifted, when they are changing nappies, changing clothes, because there is a risk of fracture, and where possible, two individuals should be handling the baby. When it comes to simple measures as changing nappies, pelvis should be stabilized so that there is limitation of movements and the risk of fracture is reduced. Infants with brittle bone disease, especially the ones with severe manifestations, don't feed very well, and it's important for proper positioning during feeding to decrease pressure on the backbones and also to keep them comfortable, especially if they have fractures and they are suffering from pain. Gentle burping is required with soft taps because there is a risk of fracture. Children with brittle bone disease with severe manifestation also have reflux disease with sickness, which is not uncommon during feeding. So they may require feed thickness and anti-reflux medication. So they should contact their doctors if that's a major problem. Clothing, again, lightweight cotton clothes is very helpful. The babies do sweat a lot, and this helps to absorb the sweat. They should have a loose neck so that the hands and the changing of the clothing is easier. And again, there are special clothes which could be used, which has got buttons and snaps on the side, which limits the movement of the limbs and prevents them from fracturing. Adequate care should be taken during bathing as well, and again, it's usually helpful to have assistance while these children are putting to bath. A sponge cushion on the bottom of tub could be used to prevent pressure and fractures. It is important to recognize fracture. And it could be an injury which has been witnessed, or if there is a snap which is heard. In very young ones, it could be limitation of movements of the limbs, irritability, and swelling and pain, which should alert for fracture. Despite best of care which these infants get, besides all the precautions families undertake, fractures still occur, and therefore it's important that one is always looking out for any signs of fracture which could develop. Now, management of fracture, the first thing is don't blame yourself or carer, because even the best possible care you would give to the baby, there would be fractures, and it's important to recognize early. Look for deformities of the limb. If there are deformities, then there is definitely a very serious fracture which has occurred. And once you are assessing and managing fractures, it is important to provide adequate pain relief. So assess for the pain and discomfort this infant is having and provide painkillers. There may be a cast which may be required for pain or immobilization for healing. And if that is being done, then it's very important to make sure that you follow instructions to keep and care for the cast. Keep it dry. There should be gentle movements of fingers and toes, and there should be limitation of physical activities when the cast has been put in. And also change the position of the child to prevent skin rashes and sores when the cast has been put in. Now, for diagnosis of fractures, it is by taking an X-ray, but there should be proper handling during procedure when X-ray has been performed. So it will be important to tell the radiographer that the child has brittle bone disease, so they would take extra precautions when they are positioning the child for fracture. And it's also important to avoid taking unnecessary X-ray procedures, especially if brittle bone disease is very severe and there are frequent fractures. If there is no deformities, we generally advise to avoid taking unnecessarily X-rays for each fracture which may occur. Now, I'm not going to discuss too much about dentition, as you're going to have a presentation on dentition about management of teeth. 50% of children with osteogenesis imperfecta are affected with dentinogenesis imperfecta. Usually in this condition, the teeth is opalescent brown, they're blue in color. Usually teeth erupt with deformities, so if they are normal when they're erupting, it is likely that the child has escaped dentinogenesis imperfecta. There is a risk of dental cavities, so it's very important to maintain good hygiene. Now, one of the characteristic features of osteogenesis imperfecta is that children are hypermobile, they are double jointed, and in some children this is much more of a problem than fractures itself. because hypermobility causes significant aches and pains. They're able to do a lot of activities, but then subsequently they suffer from significant aches and pains. So they would require painkiller. It is important that orthoptics and podiatry input has been provided to these children from very early age, and they would also require occupation therapy and physiotherapy support for strengthening the muscles, which can then support the joints and reduce morbidity associated with hypermobility of joints. Now, it's very important to take care of back because the backbones can crumble. They are the soft bones which are prone for crumbling, and crumbling of backbones is known as fracture. And therefore, it is important that one should be aware that this is a complication which can occur, and this should be carefully monitored for. Here on X-ray, you can see on the left side, there should be like a square blocks, these backbones, but you can see that there is crumbling on the top and the bottom there. This is side view of the backbones, and from the front view, you can see that there's reduced height of the backbones. And when we are managing children with brittle bone disease, it's important to be aware of this complication and to manage them as early and as quickly as possible. Now, what are the symptoms of vertebral fracture? Children will usually present with back pain. Pain worsens when they're doing activities. It worsens on standing, walking, and bending over. Some of the children have significant pain and they have difficulty in going to sleep. There could be loss of height because of crumbling of the vertebrae. There can be change in curvature of the spine. There could be either a sideways bending or a forward bending of the spine, known as kyphoscoliosis. And in severe cases, there could be breathing problems and there can be pain in hip. And on some occasions, it could be completely silent with no symptoms. And since we are aware of this condition and since we monitor it carefully, we have found that a lot of children are now diagnosed with vertebral fracture with no symptoms at all. Children are full of spirit. They don't complain much like we all do. And they have got a pain threshold which they tolerate very well, and they don't present with all these symptoms. And on an yearly X-ray scan, or when we do DEXA scans, we look at the backbones, we find that they are vertebral fractures which have silently developed. So it's important to be aware of this complication and to look out for it and treat them as quickly as they have been diagnosed. Now, it's important to care for back, and it should be, and children should be asked to avoid anything which puts undue pressure on the spine. For example, trampolining, horse riding, adventure sports, contact sports. It's very challenging because if you try to tell a child to avoid doing this, won't be happy at all. Carrying heavy loads. So these are all important instructions we provide families to take care of back to prevent vertebral fracture. But at the same time, children should continue to exercise because exercise strengthens muscles, which then further strengthen bones. So precautions should be taken, but they should be encouraged to exercise, which are safe for their back. Swimming is a very good exercise for them. Some form of physiotherapy and occupation therapy is required in all forms of OI. Those who have severe manifestation require much more intense physiotherapy and occupation therapy, but those who have mild OI still require because they could suffer from hypermobility of joints. Speak to your medical team and they will advise you about the intensity of physiotherapy which would be required for your child. Management of vertebral fracture, painkillers to manage pain, and all children who have vertebral fracture require intravenous bisphosphonate therapy to improve their vertebral bodies. Now this is a vertebral fracture. As you can see here, there is significant reduction of height of the vertebral bodies, and with bisphosphonate therapy there is progressive improvement on these vertebral bodies. It's important to recognize fracture and manage them because the chances of improving the vertebral height is less after a child progresses through puberty. So our aim is to make sure that these vertebral fractures are identified and their height is improved before they have progressed through puberty. Bisphosphonate therapy also helps in improving the bone strength of the long bones. So the indication for bisphosphonate therapy in children with brittle bone disease is vertebral fracture, or if they have frequent long bone fractures. So what are the side effects of bisphosphonate therapy? First reaction usually causes a lot of flu-like symptoms with temperature. It's usually managed with paracetamol and Nurofen, and it tends to improve within 3 to 4 days. It can cause hypocalcemia. Newer agents are much more powerful, and they're prone to cause hypocalcemia. But this can be reduced by making sure that they have adequate vitamin D stores as well as adequate calcium intake before and after infusion. Bone pain is reduced with frequent use. It's a very rare complication of having transient uritis and uveitis with bisphosphonates. So it's a safe medication, but it should be cautiously used. Overuse can also cause major complications with bones. So what's the current evidence about using bisphosphonates? So we've got around 20 to 30 years experience of using bisphosphonate. We know that with bisphosphonate there is satisfactory growth and increase in height. It doesn't impair with pubertal development or pubertal growth spurt. And if used at an adequate dose with a proper schedule, there is no mineralization defect. There are these sclerotic lines which develops. These are the calcified cartilages, which develops on bones because of bisphosphonate therapy, but it doesn't have much clinical significance. And there is a normal fracture repair. If there is a minor fracture, we don't stop bisphosphonate therapy, but obviously if there is a major displaced fracture, we tend to delay infusion of bisphosphonate therapy by a few weeks. Walking can be affected in brittle bone disease, and it all depends on severity of brittle bone disease. It's important to be positive and support in the endeavor in walking. Mobility aids may be required in some children for improving their walking. If there is significant deformities of the bones, rodding procedures could be performed to help them in mobilizing. And this is one of our patients who had significant deformities of the limb. Rodding procedure was performed to straighten the bones and the limbs, and there is an improvement in mobility after rodding procedure and with bisphosphonate therapy, a combination of that. Vitamin D and calcium supplementation is important. In itself, it won't prevent fractures. In itself, it's not helpful for curing vertebral fractures, but it's important to make sure that vitamin D stores are maintained by daily supplementation, and children should be encouraged to have adequate dietary calcium intake. Thank you very much for listening, and I'm happy to take questions.